Good morning and Assalamu alaikum. I'm Mohammed Aljohani. I'm going to present our first publication we had in the series of informatics radiology. A brief and little story. In 2006, King Abdulaziz Institution for Talent start a national program. Basically, they recruit a student from different schools and they establish a career path for them. By the end of the program, they had a recommendation and they recommend for me to study medicine and information technology and focusing in the management. Since we live once, I decided to combine all of them. I graduated dental school, baccalaureate degree, then I had information technology, health informatics master degree. Now I'm finalizing the PhD in oromaxillofacial radiology. I'm working now as a board member in Saudi Association for Health Informatics, organized by the National Guard. This revolution, the same happened in every field. For example, in the health data, around the 2009, the digital health they started, and around on that time, the data health reconstructed to the digital platform. So the data mining had to take a place on that. And we appreciate what data mining could do for us, either as a clinician during the decision making, or as a manager, which decision we had to do during the crisis. And we felt that during the pandemic, COVID-19. And we appreciate the development we had during that period, which accelerates what we have facing today and the theme we had. In the last of 2021, we put a face on a tool. This tool was artificial intelligence. Now, everywhere we go, AI. So we took the advantages of this tool. And we would like to establish, and we wrote a code for detection model. Since I am in the industry field, one of the most common diseases we have, it's periodontitis. Basically, for non-dentist audience, it's inflammation of bone. So the bone is lost, which consider it the most common diseases. Okay. When we're building the code, we would like to machine to learn what is the normal and what is abnormal. And like usually, what we would like to have, we give an example for the normal situation, and we explain to the model what is normal and what is not normal. For example, in this case, we consider it normal regarding three characteristics mainly. The first one is the pointed cristalloalveolar bone that indicate that tooth is normal. The other one, the distance between the cristalloalveolar bone and cemento-enamel junction. Also, the trabecular bone, we can appreciate it. These characteristics, we consider it as a normal. So we put that images to the machine and we explain it to it. So when the machine saw alteration in these characteristics, will consider it as a disease. So in 1999, they established a classification for these diseases. We had four classification. Mainly, the first one is mild, moderate, severe, and based on the depth we do it in the clinic, we can appreciate. The beauty is a lot of research done to treat the case, but there is no or limited study to predict the outcome of these treatments. So we took the advantage and we established and creating the code. So our aim was, first of all, build the code so we can use it and predict the disease of it there. So when we have an image, the machine will tell us it's normal or not normal. And we did an amazing job in regarding that objective. The second goal is to classify these diseases. Is it mild? Is it moderate? Is it severe? And we need to do a lot to reach a level when we're confident enough so that the code, when the outcome said it's a mild, it's a mild. When it's a severe, it's a severe. We have the opportunity to say it's normal and disease, but still we are under investigation for that level. And we do it a primary result. For now, we reach until 95% of accuracy, which is good, but still we need to reach 99. So what we did, we took IRB approval. We retrieved 1,700 images, and we calcified them. This is the process we did. When we calcified them, we had to compare what is normal and what is the standard or gold standard for the cases to let the machine learn from that data set. After that, we write in the code to resize the images itself. And since our outcome is to compare disease, non-disease, so it's binary, also the leveling of each disease, so it's multi-level. Demographic data, the only issue we faced during collecting the images was the imbalanced data. And when we wrote the discussion and the result, it was one of the areas for improvement in that field. Because unbalanced data, when the machine when we supervise the machine and we try to let's take a decision for that, when it's unbalanced, it's a challenge for us because the overfitting problem. So we have these three names, we know about them, and there is an interaction between them. Artificial intelligence, it's a field of information technology. However, the machine learning and deep learning is a subset of this field. So when we write a code, there is a set or a library we can use it from that. One of the library was the visual geometry groups, 16. They use a 16 layer. And we can modify the layer we needed. So the input is clear, which is the images. And the output, this is the neuron we needed. Okay. When we said neuron, we think about the human body, basically the same. We try to let the machine, to let her learn from itself. So when we had the image, the machine will recognize it by transferred library. When they decide that truth is that extent and the edges of the tooth, the coding, the 13 layer, it's 16 overall, but the 13 layer is fixed, so we don't need to build it from the scratch, and this is the beauty about it. But we can build it, the last two layer. The last neuron, the dense layer we have, either we have it as a two neuron for disease and normal, or 4 neuron for the leveling itself. In each layer, we give the code the opportunity to drop 50 neuron to overcome the overfitting of the disease. Because imagine that the machine or the code passing an image, then when we test it, the image is still saved there in the back of the code. So by default, the code will identify the image. And we assume that the code is working, but in fact, it's already saved in the code itself. So we emphasize on the 50% of the images to be dropped to overcome the overfitting problem. So when you use optimizer, we go with RMS, non-Adam, because the characteristic of the image and the process it needs a high RAM, a fast processor to overcome the delay in the machine. So we use that optimizer with a batch size 16. So every image we bought as a package of 100, and out of these 100, 16 of them retake it again. The result was significant when we compare normal and disease. However, when we studying the classification of each disease, we can appreciate the difference between the training in the blue and the orange with the test. There is a gap in that area. And that was the area of improvement to overcome that issue. We need to build a code. We are confident enough to overcome that. While disease and non-disease, almost the gap and the accuracy, when we compare sensitivity and specificity, it's almost above 70. So when we compare it to other published articles, it was good enough for that, because the maximum accuracy level they published was 81. And when we compare between the code and the gold standard, in the training, it was the sensitivity is high, which is good, 140, while the specificity was good for the testing model. There are two articles published in 2018 and 2019. Basically, they focus on the posterior teeth, and we have a hypothesis that the posterior teeth, the system has accuracy more than the anterior teeth, since nobody studied the anterior teeth, so that the assumption it need to be validated. So we conduct that kind of a study, and the result was 75% accuracy for the anterior teeth, comparing to the posterior teeth was 79. One of the limitation was image extraction. We had to recruit 5 technicians only to extract the images. It was 1,700 images. So when we have a large data set, we need a high recruitment to overcome that issue. Also, that kind of data set, the image itself, the BA, it's 2D images. So now we're planning to have it as a CBCT, 3D images, not stitch, which overcome the unbalanced data. This is the recommendation, and thank you.